Hi there, I'm Matthew Price, here at TCT 2019 on a lovely day in San Francisco with my two close colleagues, John Lasala from Washington University in St. Louis, and Ignacio Inglessis, who is from the MGH. And we're here today to talk about patent foraminal valley closure, transcatheter PFO closure, and talking about some of the complexities of PFO closure and some issues surrounding the disease state and managing PFO patients. So thanks for being here today. And we thought we'd start our discussion over the next hour to talk about complex PFO closure. And PFO closure usually is a fairly straightforward thing, but John, you taught me years ago, you've taught many people, and you've taught me years ago that PFOs come in several different flavors. Yep. There's the PFOs with a thick septum secundum. There are PFOs with a long rigid tunnel. There are PFOs with aneurysmal septums, and there's a PFO with a combination of those things and a PFO with none of those things.
Right, all of the above.
All of the above. So 95% of the time, PFOs are pretty straightforward, but sometimes they're not. So what we thought over the next hour, we talked earlier, is to show some cases to highlight how to handle these outliers in terms of anatomy. And then we'll talk a little bit about how we've built our multidisciplinary clinics at MGH and at Washington, St. Louis, and at Scripps Clinic. And then talk a little bit about how to manage the patients post-procedure.
Great, yeah.
So with that, why don't we begin? I thought I'd show a case to start, and we'll have some really hopefully vibrant discussion about that. So we'll talk about this case here. So we talked about the complexities of anatomy. So this case will highlight some of those. So this is a patient of mine who was a young man who presented with a cryptogenic stroke. The workup by MRI and of his neurovasculature and so forth led to nothing except for this patent foraminal valley. So you see, this is the baseline transesophageal echo. On all of our younger patients with stroke, we get a TE just to make sure that there's no funny business going on in terms of cardioembolic sources. And here is this patient's PFO. So on the left, you see a long axis view of the interatrial septum, and on the right, you see the short axis of the interatrial septum with color. So I'm going to throw this to the crowd, so to speak. So Ignacio, what are your first thoughts about this?
Yeah, I think obviously a very frequent situation. I tend to see this more in the older population. The thickened secundums, it tends to be more of a patient above the age of 50 or so, particularly if they're diabetic as well. They like polymerase hypertrophy. It's frequent in that kind of scenario. The first thing I'm looking at here is we have to realize that this is obviously a transesophageal echo that outlines the anatomy very well, and it's our challenge as interventionalists, if you're going to do your closures with intracardiac echo, that you have to be able to reproduce the quality and the detail of this image with your imaging technique. If you don't feel that you have that level of expertise with the intracardiac echo, I would favor that, for example, these cases are done with transesophageal echo because obviously the complexity is such that without good imaging, this would be a very challenging and potentially unsafe closure to be done.
Yeah. So John, why don't you highlight what are those complexities anatomically in this particular case?
I think some of the things that you mentioned already have got to be distinguished up there. You have more than one entity. You've got a little bit of a thickening of the secundum. You clearly have a tunnel that overlaps, although there's a big gap in there. You've got Doppler flow that's pretty much continuous throughout the cardiac cycle. And even in the early trials, before they were all positive, the one subset that was positive were the people who had atrial septal aneurysms and had a large shunt. And it looks like we've got at least two of those components up there as well. We have a little bit of aneurysmal movement of the septum primum. We have a wide open area between the secundum and the primum, and you have some thickening of the secundum itself.
Exactly, and you really see that thickening best on the long axis view, where the septum secundum, again, that's on the right side of our screen is the septum secundum. On the left side, the thinner part of the septum is the septum primum. And you do see that it appears to be a long tunnel, although you can sometimes be fooled
True.
Because if we consider the right atrial side the entrance, and the left atrial side the exit, sometimes the exit is actually in the middle of what we think of as the tunnel or that flap, right?
Right.
And it does seem, hopefully it's a little bit soft here as opposed to rigid, but we will find out. Right. So let's see what the next slide shows us here. So I do, as Ignacio mentioned, I do all my procedures by intracardiac echo. I think it's important to get a baseline TE, so 99% of the time. Sometimes you don't, but most of the time we get a baseline TE. And here is my agitated saline injection. Again, I'm using an ICE catheter here. It's bouncing back and forth with the heart between the long axis. You get a little short axis as well. You still see that there's significant dispersion of the inner atrial septum. I think qualifies for an atrial septal aneurysm. You still also see that thickness of the septum secundum. How do you define a thick septum secundum? Is there a number you use, John?
Yeah, over 1 centimeter.
Over 1 centimeter. So
we've had some as big as like 2 and 2.5.
Oh yeah.
They create very unusual challenges because there's not a good device to close all of them.
Right. We'll talk about some techniques maybe to do that with the devices we have.
Yeah.
So I would say this is, if you look at it, it's probably about 10 or 12 in terms of thickness. And you see also, as you mentioned, there's a large shunt. I don't want to get too sidetracked here, but we can talk a little bit about size of shunt and indication for closure. You mentioned the early trials, it seemed that an aneurysmal septum did confer benefit, probably because that goes along with a larger shunt.
With a shunt.
I'm often surprised when you do intracardiac echo, you have patients who have a small shunt on transthoracic or TE, and then you do the ICE and it's a huge shunt.
Yeah,
so
I think that's a great point because your referrals, many times they mistakenly say, well, we can't find any other source for the embolism, and there's a small PFO, which is probably insignificant. I think the things you can say for certain are that if there's a lot of bubbles, if it really opens up, it's large. But if there's only a few bubbles, you don't really know if it's large or small.
Exactly. So I think that clearly a large shunt on non-invasive imaging is a strong indication for closure. However, a small shunt is not an indication.
Good. Double negative, but it still works.
Exactly. So, and remember that in the clinical trials, for example, in the reduced trial, okay, that there was no interaction between the treatment effect of PFO closure and the size of the shunt.
Exactly.
Okay, so that's important.
Yeah, but there's another twist to this story is that, I don't know in your parts of the country, but at least in the Northeast, many insurance companies are now mandating that the size of the PFO is taken into consideration for approval of closures. For
I think that's terribly wrong. And the data does not support that.
Right. I just run into that recently. Unless you use the key buzzword atrial septal aneurysm or large shunt.
Exactly.
Either one of those two.
Right.
Many of the insurance companies.
Even more so, we are actually, a couple of insurance companies are mandating that you document the number of bubbles, and you have to physically say more than 30 bubbles on the left atrium.
Right.
So
the data doesn't support that, and also the sensitivity of our testing does not support that.
Right.
So
exactly.
You have to really, we can talk about this more in a little bit, but when you do your TEs or your transthoracic echoes, you got to make sure the bubbles actually make it to the PFO and are not shunted out of the way by IVC flow.
Right.
So let's go on with this case. So we have a case of the aneurysmal septum, you have a large shunt, a thick septum secundum. So, all right, so let's actually go back one before we look at this. So tell me, and with this case, what, Ignacio, device size selection for this particular, is there anything you go into, you balloon size?
Right.
Do you change your approach?
So I've gone through the process of doing balloon sizing routinely a decade ago for PFO closure to now doing it more as a subjective approach. I think that if you routinely balloon size, particularly in a situation like this when you have a very thin priming, and if you're not careful with your technique, you can make this PFO big and then potentially start thinking that even PFO available devices are not appropriate, and you might start reaching out for ASD occluders or so forth. My basic teaching to my fellows is that anything that looks different than a straightforward short tunnel, normal thickness, then use the large device. It's either with the Cardioform 30 or the Amplatzer 35, because I think the ability to close a defect like this can only be achieved with large devices.
Yeah, I think that's a key component. Simple, straightforward PFOs like you described earlier, it's 25.
Right.
Anything else you have to think about sizing up because you need more coverage.
Right.
Right.
I mean, a large secundum, the device itself, you have to think about it like a Pac-Man appearance, right? It has to swallow up the secundum.
Right.
If the device isn't large enough, it's going to shift off the secundum. Now, when you release it, you have tension. Maybe it'll go back up, or maybe it goes back down into the tunnel, and that, of course, would be a reason for trying to go up, having to go retrieve it.
So the key is to make sure that the right atrial disc is fully on the right side of the septum secundum.
And engulfing the secundum.
And engulfing, grabbing that. You don't want it to fall into the tunnel. And so that'll also play into how we actually deploy the device. Right. So I don't balloon size anymore. I used to, I don't.
Right. I think we're all in the same camp. We learned something from it, but we also saw that there's some downside to it. But now we can look at it and say, if it's really abnormal, big atrial septal aneurysm, thickened secundum,
long tunnel,
we probably got to go size
big.
up.
Right.
Go
so
big.
I chose a 30 millimeter cardioform device here.
Good.
So we're talking about the actual technical aspect. So now on the left side of your screen, you see the ICE image. I'm now on the short axis, which is a nice view to actually deploy the device. And I'm pulling quite robustly on the entire system back so that I am really nestled nicely into the interatrial septum on the left side. And you will see on the fluoroscopy side here that before I even begin to deploy the right disc, I have concavity of the left disc. So I am clearly touching and actually retracting a bit into the septum because in the PFO, it's very hard to pull the left side through to the right side. Yeah. ASD, that's a different story.
Right.
So here, what I'm really trying to do is I want to make sure I get all that material on the right side of the septum, the right disc. And here I'm forming the right disc. You can even see the right disc seems maybe even slightly constrained here on this disc, but it has to do more with the angles. I think I gave it a little tug to fix that.
Important also, Matt, to highlight that you should deploy the right disc in the ICE view that where you see the septum to be the thickest. So you can guarantee that the right disc is actually covering that, the thickness could be variable. In the bicable view, it might be thinner than in the short axis or vice versa. So as you've done in this case, you're deploying the right disc when it looks the thickest.
Excellent point. This is also something that we would do with a long tunnel is to retract quite robustly. The other thing, in particular, the cardioform device, because there's a locking system, you want to make sure that the discs are as close as possible so that you don't have what's called a missed lock, but that is extremely rare.
Yeah, so sometimes you come into context with a long tunnel that they're floppy and they yield.
Yes.
As you're pulling this together, it's actually pulling down, right? And it's realigning itself. But some of the long tunnels have fibrotic attachments. Basically, shortly after we were born, when these should have closed, these are sort of partial closers. There's a lot of overlap. It's a long tunnel, but portions of it have scar tissue on it. Those are much more difficult to align with. And I think maybe in a later case, we'll see how best to handle that.
Right.
So here now is on the left, the ICE image of pre-lock. You see here, I'm very confident that the right atrial disc is on the right side, is not going to fall into the septum with patient respirations. It's an important thing if you have a patient who snores during the procedure. That's a good sign, because you see that the
huge excursion
as the patient snores. That's called the Mueller phenomenon, the Mueller effect, as opposed to the Mueller maneuver, as opposed to the Valsalva maneuver,
right?
Which is
no relationship to me, by the way. That's right.
Okay. We're not going to investigate your snoring here, the Mueller investigation. So, so here we have a very nice grasp of the septum secundum, and you see now the lock on the right side. In fact, the device hardly moves at all with the lock. This shows you how well nestled it is in there. Yes. You see two things. You see the concavity of the left disc, and you also see some concavity of the right disc as well. So we have a nice snug effect. Something I did not mention is I tend to save the ICE video as I'm deploying the right disc, to make sure that you capture the septum secundum. Good. It's more important than cine.
Right. So a couple of other key elements. You have that Pac-Man appearance. You can see that your right atrial disc is up to the top of the secundum.
The LAO projection. Yep.
In this projection, and also on your ICE image, beautifully encapsulated. And the other thing is that you've got this extreme of diameters. You have a 1.2 centimeter secundum, and then you have this 2 little millimeter floppy atrial septal aneurysm. So the device is very nicely accommodating those two extremes, a very thicker component and then a very floppy, thinner component. And it's the concavity is really representing
Right, the soft device itself nestles in.
exactly that it's nestled and it's opposing it well, and that gives you the best chance of a long-term closure with a bubble study that it'd be negative at the end. In my experience, the combination of this atrial septal aneurysm and a thick secundum is the one that's most likely to still have a positive bubble study.
Right.
But when it looks like this, you got a good chance.
And here you see actually, to that you see on the left the final result by ice without bubbles, and you see it's quite nice and flat and organic. Look at the short axis, looks really nice, doesn't it?
Yep.
And there was zero
Great
bubbles.
result.
Yeah, great result.
Zero
Fantastic.
bubbles.
Good.
Well, thank you very much.